Good afternoon, everybody. This is one of the first significant in-person, on-campus events to happen in a very long time. And we are thrilled to be doing it. The Chancellors Health Policy Lecture was established quite a number of years ago, and each year brings a distinguished health policy speaker to our campus. So we are very excited about this. I'm Joanne Spetz. I'm the director of the Philip R. Lee Institute for Health Policy Studies, and we would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. We would like to note that for today's talk, we will have in-person question and answer time, and for people on Zoom, there is a question and answer box, and we will make sure to moderate between both the in-person and the Zoom questioners. So to kick us off, I would like to introduce Dan Lowenstein, who is the Executive Vice Chancellor and Provost and the Robert and Eleanor Aird Professor in the Department of Neurology here at UCSF. He received his bachelor's in mathematics from University of Colorado and his MD from Harvard Medical School, and then completed his neurology residency training at the best medical university in the United States, also known as ours. He's a clinician scientist who cares for patients and studies both basic science and clinical aspects of epilepsy, and has been actively involved in advancing the cause of epilepsy at the national, international level. So I will introduce him to kick us off.
Thanks. Thank you, Joanne. Thank you very much, Joanne, for the introduction and also for your wonderful leadership of the Philip R. Lee Institute for Health Policy Studies. And on behalf of Chancellor Sam Hawgood, whether you're here in person or those of you online, thanks for attending the 2022 Chancellors Health Policy Lecture. And I'm honored to be here today as we continue to bring outstanding health policy leaders to UCSF, providing different perspectives on current health policy issues and highlighting the crucial role that health policy plays in the lives of our faculty, our fellows, our learners, and our trainees. And our goal here at UCSF, as we all know, is to advance health worldwide. I actually like to think of it as lessening the suffering in the world through our teaching, research, patient care, and community service missions. And Joanne and her team at the Philip R. Lee Institute for Health Policy Studies are a very, very important part of that mission. Now, for those of you who may not be familiar with the Institute for Health Policy Studies, it provides leadership for policy implementation, making a major impact on how we as a nation implement policy that influences health, healthcare costs, clinical practice, and population health. And I'm looking forward to celebrating the Institute's 50th anniversary in the fall of 2023. Now, I don't need to tell you that together we've faced over 2 years of unprecedented concurrent challenges: a pandemic, national division, racism, attacks on LGBTQ plus and reproductive health rights, and dare I insert the news that we learned last night. And there's climate change and war, which has me heartbroken, and too many other harsh realities. But thank goodness that researching policy, educating others, and advocating for change is where we here at UCSF can lead and make a valuable, lasting difference. Thank goodness that we get to do the work that we do every day. And our speaker today epitomizes the goals and values of the Philip R. Lee Institute for Health Policy, and indeed the goals and values that we share at UCSF. And I'm really excited to introduce Sandro Galea to present the 2022 Chancellors Health Policy Lecture entitled Rethinking Our Approach to Health After a Pandemic, Lessons Learned from COVID-19. He's a physician, an epidemiologist, and an author. Sandro is Dean and Robert A. Knox Professor at the Boston University School of Public Health. He's been named an epidemiology innovator by Time Magazine, a top voice in healthcare by LinkedIn, and is one of the most cited social scientists in the world. Sandro has served as a field physician for Doctors Without Borders, and he has held academic positions at Columbia University, the University of Michigan, and the New York Academy of Medicine. And it's the very work being done here at UCSF, as well as the work of leaders such as Dr. Galea, that will bring us through to the next solutions in health. Please join me in welcoming Sandro to UCSF. Sandro, the podium is yours.
Good afternoon. Thank you very much for having me. Thank you, Professor Spetz and Lowenstein, for those kind words and for having me here. It's actually really wonderful to be here in person. I realize that we as a world still have to settle on how we're doing academic engagements in person and remotely in future, but I don't think there's a substitute for actually being around colleagues who can stimulate and challenge our thoughts. So thank you all for being here. So I'm going to talk about COVID because COVID. But my role here today is to try to perhaps sharpen our thinking and provide a framework for how to think about what we've just been through. I realize there's a certain arrogance in saying after a pandemic. I'm not sure it's after a pandemic, but nobody is sure either, so just bear with me on that. But really what I'm trying to do is to say, how do we structure our thoughts about what we've just been through, what we're going through, to the end of surfacing what we should learn from the moment. And to the end of, I would like to surface how I'm thinking about these things so that you can actually agree or disagree, so that we can collectively do the kind of scholarship that I think we need to do moving forward. I agree very much with Professor Lowenstein that I wake up every day glad to be doing what I'm doing in a time, particularly in a time like this, because I feel it gives us meaning and purpose. And my goal here is to try to sharpen that purpose. So having said that, let me start by talking about the pandemic. I'll start by putting the pandemic in slight historical context, although I'm not going to spend much time on this. This is a picture from the Black Death in Europe, which killed about a third of Europeans at the time. It was really, this is in the 14th century. And, COVID, while it is for all of us in this room, certainly the seminal pandemic of our lifetime so far, hopefully for our lifetime's period, is one in a series of pandemics that have struck the world, that has really shaped the world. I want to show a picture of this. This is a physician in a time of the Black Death and wearing a mask, which really shows that we haven't come that far really in 700 years, although the mask, of course, was a little bit more colorful then and had religious undertones. At the beginning of this pandemic, La Peste by Camus became a bestseller, and this was a fictionalized account of a pandemic hitting North Africa, but anybody who's read it actually will recognize how much he got right, actually how much of what Camus wrote about roughly reflected on what happened right now. All to say that what we're going through isn't that new. And I find it very humbling to think that what we're going through is not that new, because in some respects, it feels like we should then have known better on a number of things. We've all been through the ups and downs, the peaks and valleys of cases, the ups and downs, peaks and valleys of deaths. But I think you'd all agree that much of the time, it has felt like this. This is a snapshot from New York Times at one point in 2020. And I show this picture because the Times used red to illustrate number of cases. And you'd all agree that if you were an alien from outer space landing on the planet, you didn't know what this map was, you would feel like it's nothing good, right? It felt like the whole country was on fire. And the whole country has felt like it was on fire for the past 2.5 years. And I think it's important to recognize that fire is a cost of human lives. And I think it's very difficult. I find it difficult, trafficking in population health, to remember that we're dealing with lives, we're dealing with people, we're dealing with deaths. We're getting close to 1 million deaths now. And that is like 1 million neighbors, cousins, aunts, lovers, grandparents, mothers, fathers, right? And that is a toll that is really hard to wrap one's brain around. It's really hard to remember that these are 1 million people who, many of whom otherwise would not have died if it wasn't for COVID. So this is a tragedy. And nothing redeems a tragedy. But certainly, we disrespect the tragedy if we don't learn from it. So part of what I've seen as my mission in the past year is to help to nudge us towards saying, what are we learning from this tragedy? At least let us take and extract positive from the point of view of learning. I do want to make one caveat that I'm talking here very much a US context today. I think there's an equivalent talk, an equivalently important talk that talks about the global context. I just use one quote here from Ecuador, which has one of the largest outbreaks in the world, which is one day there were no patients, the next there were 5,000 looking for beds in intensive care units, sort of to give you a sense of the magnitude of this globally. And I do want to end my introduction by pointing out this. This was the headline of the New York Times in May 24, 2020. Not that long ago, right? It was about 2 years ago. And it said 100,000 deaths were an incalculable loss. And we all remember May 2020. 100,000 deaths felt like this enormous loss. And now we're getting close to 1 million. And that gives us the sense of how important this was. And I feel like, as with many other tragedies, it's actually hard for us to even get perspective on it until we're distant from it in history. It's going to take us some years to get perspective from it. And part of what I'm trying to do is to make sure that we don't go through that time with our thoughts hardening without thinking critically about what we've just been through and how we should be taking learnings from the moment. So having said that, I'll start this way. So what did not go well during COVID-19? I realize with the introduction, you're all throwing up your hands in the air saying, well, everything did not go well. Well, that's true, but I think it really helps us to, again, to be disciplined and say, well, let's think critically. What did not go well? And I would argue 3 things did not go well. Overall burden, inequities in burden, and social fracturing. So let me talk about each one. I'll start with the overall burden. I've already made the case, certainly has felt like the overall burden has been bad, but it hasn't just felt like it's been bad. Empirically, it's been bad. This is this looks at the regions of the world. The red is US and Canada, although Canada is a very small part of it. And really just to show that at every part of the pandemic, sort of like we've been worse than other countries in a per population basis. When you look at cumulative deaths, on the left you have cumulative deaths through the pandemic. Dark line is the US, on the right is deaths during Omicron, that we've exceeded all other high-income countries in terms of deaths per capita. The US is not, if you look at the country tables, it's not the highest in deaths per capita because some small countries have higher rates, but certainly we have had the most deaths per capita, most illness per capita of any high-income country. And we have paid the price in terms of loss of life. COVID became the 3rd leading cause of death in 2020, and the 2021 data are not out yet, but it's almost certainly going to be the same. I know we're sitting here in 2022, and me saying that COVID was the 3rd leading cause of death after heart disease and cancer is like, meh. We're like, yeah, we know that. But if I were to do a thought exercise for a second and say to you, 2025, there's going to be a new disease you've never heard of, named with a sequence of letters that you've never put together before, and it's going to become the 3rd leading cause of death, I would suggest that sends a chill down your spine and then makes you quickly rush and say, wait, what can we do to prevent it? That's what COVID was. Came from nowhere, sequence of letters never heard of, became the 3rd leading cause of death. And of course, it had an effect in terms of life expectancy. This is life expectancy in downturn in 2021. We've collectively lost probably about 2 years of life expectancy in time of COVID, which is the largest single drop we've had since since the 1918 flu pandemic. In some groups, it was in World War II. So that's overall burden, inequities and burden. So this burden of COVID has been lived very inequitably. It's been lived inequitably on multiple dimensions, all dimensions of identity and disadvantage. This looks at very simply at white and black life expectancy. This is the white downturn life expectancy, black downturn life expectancy. When you look at overall death rates of black Americans versus white Americans, the orange is adjusted, the blue is unadjusted. In terms of adjusted, black Americans had about a 2-fold greater death rate than did white Americans. And we're going to get to that in a second. When you get to life expectancies, when you compare large gender ethno-racial groups, on the far right here you have white women, life expectancy drop of 0.7. 0.7 life expectancy drop, by the way, is huge. It is, we have not had a single group with that kind of large drop since World War II. World War II had young men who were sent off to war, had the largest life expectancy drop. The life expectancy dips we've had since then have been in the 0.1, 0.2, 0.3 range. So 0.7 is huge. On the far left, you see black men who had a 3-year drop in life expectancy. And of course, I'm showing black-white differences here because it's something that that captures a lot of the underlying social and economic context that determine what happened in COVID here. But I could equally well show you this by many other axes of identity that is linked to marginalization. So just one concrete example. This looks by education. So this is different racial ethnic groups. This is American Indian, Alaska Native, Asian, Black, Latinx, etc. And each of these goes from less education to more education, and this is mortality. So you see as you go to more education, lower mortality, more education, lower mortality. And that's true consistently across racial ethnic groups. And I can show you that also by income, I can show you that by wealth, I can show you by immigrant status, etc. So on all dimensions of disadvantage that pre-existed before COVID. We had this patterning of COVID morbidity and mortality, which I'll get to in a second. And the third thing that went wrong is social fracturing. So COVID hit the country at a time really of unprecedented civil unrest. This, going clockwise, looks at civil unrest around gender equity, income inequities, climate change, racial inequities. And this came at a moment where then COVID hit. It was coupled with the shooting and killing of unarmed black men and women, which resulted in the summer of 2020 in quantitatively the largest civil unrest that this country's ever had, larger even than 1968. And what it represented, right, was this enormously legitimate outpouring of anger at these deep injustices that had characterized what the country looked like long before COVID. And COVID just brought them to the surface. And of course, what one, I think, should be asking is, why hadn't we had these outpourings before? Because everything that happened in COVID had already been there before, and COVID brought it to the surface. And then complicating things in terms of what went wrong during COVID is that this became intertwined with political perspectives, with hardening of political positions, and social challenges to all manner of efforts that were happening in public health, from the big, in terms of civil unrest around closure of schools, to the perhaps smaller, to sort of arguments about face masks, to arguments about the science and the politics of things like face masks that became symbols of things that are much larger than they actually are. So all of that happened during COVID. So the question becomes then, what caused these problems? So what caused these three problems during COVID? And I would argue there are three things that caused them: technical shortfalls, inequities that existed before, and communication challenges. So let's start with technical shortfalls. Ironically, although I think technical shortfalls were a big part of the problem in COVID, COVID also represented an enormous technical triumph. And this was the technical triumph represented by vaccines. I mean, we got to these vaccines in 8 months. We got to vaccines that were more than 90% efficacious in 8 months from diagnosis of the pathogen. The fastest ever we had ever gotten to a vaccine from the time we started trying was mumps, which took us 3 years. And these mRNA vaccines seemingly came out of nowhere. As I'm going to argue in a second, they didn't come out of nowhere at all. They actually came out of decades of investment. But 8 months we got to vaccines. It's hard to remember now, but in June, July of 2020, we were having debates about what would we do if we got the vaccines that had a 50, 60% efficacy. But instead we had 2 vaccines that were more than 9% efficacious. So that's a technical triumph. Of course, the technical triumph stopped very quickly when it gets to our ability to vaccinate the population. This is share of population vaccinated. This is us compared to other high-income countries. And this is booster dose us compared to high-income countries, where actually we fell behind all other high-income countries. You know, there's a glass half full argument here, which is to say that we actually did get at least 1 dose of vaccine in 95% of people age 65 and up. But as everybody here knows, that vaccination rate was deeply uneven. It was deeply uneven across the country, where you have many counties where really we had 30%, 40% of people at most vaccinated. And that was just with the first set of doses. When it comes to boosters, we essentially collectively gave up as a country. Like really, there's no place that's more than about 30% of people who are boosted. And worst of all, in terms of the technical failure of vaccinating people, is that in our efforts to vaccinate, we gave realization to the 50-year-old, one of the 50-year-old canonical laws of health policy, which is the inverse care law. So the inverse care law, which is people who actually need help the most, they're the ones who are least likely to get it, is exactly what happened in the context of vaccination. So this looks at vaccination rates by counties. The bubbles, the top row is the most vulnerable counties, the bottom row least vulnerable. And what you see is higher vaccination in the least vulnerable counties compared to the most vulnerable counties, which really is a manifestation of Tudor Hart's inverse care law writ large today. So one thing that went wrong is technically we fell short in doing the things that we knew we needed to do to mitigate the pandemic. That's number one. Number 2, antecedent inequities. I'm convinced that one of the stories of COVID that will be told for decades to come is a story of inequity. But the inequity of COVID was not inequity of COVID. The inequity of COVID was inequity before COVID. COVID simply made us aware of these inequities. Now, I know many of us in this room say, well, we've long been aware of them, that's fine. But we collectively as a society, COVID surfaced these inequities. I mean, we have for a long time, as a country, had 20-year gap in life expectancy in counties between lowest and highest life expectancy, 66 versus 87 different counties, which, by the way, is the equivalent of the difference between Switzerland and El Salvador. El Salvador has had a civil war for the past 30 years, just to give you a sense that's within this country. We've talked about black-white differences quite a bit, about black-white differences in COVID mortality in this country. And that, of course, reflects underlying inequities that have been around for decades and centuries. So when you look at black-white differences in pre-COVID, this is a timeline on the x-axis, and just going this way, unemployment, the purple is black and the blue is white Americans, higher unemployment for black Americans than white Americans, lower four-year college completion rate, lower household income, lower home ownership rate, higher incarceration rate, lower life expectancy at birth. And these are data that are well known, and all of that then came crashing to reality in COVID. And I'll explain how that became COVID in a second. But it's not just by race, right? I can again show you, just like I showed you differences in COVID by different axes of marginalization, I can show you the same thing, inequities by the same axis pre-COVID. This looks at income, at the richest 20% versus the poorest 80% of Americans. The green is the richest 20%, the brown is the poorest 80%. And what you see here is angina and heart attack, and you see a widening in the gaps in angina and heart attack for the 20 years leading up to COVID. So there were inequities in health that preceded COVID, and there were inequities in the social and economic conditions that we needed to align to protect ourselves from COVID. So when COVID hit, it was a novel pandemic, a novel infectious agent in March of 2020. We were all in a panic. Understandably, we didn't know how to transmit. The only thing we knew is that the way to protect yourself from a novel infectious agent is not to touch other people. That's the only thing we knew, right? Well, who could afford not to touch other people? Well, it was people who actually had the economic means to do so. And those economic means are not evenly distributed. Here's inequity in economic means. The National Disaster Emergency Declaration is declared. The red is the poorest 20%, the gray is the richest 20%, and this is a proportion of population staying home. As soon as you declare a disaster, who stays home? It is the people who can afford to stay home. And in fact, these are data from the Bureau of Labor Statistics. This is income quartile. This is percent able to work remotely. The higher income you have, the more likely you are to be able to work remotely. In fact, across the country, it's always a bit sort of difficult for those of us in rooms like this to wrap our brain around. 65% of working Americans never worked remotely a day during COVID because they did not have the opportunity to work remotely. We, in this room, everybody we know has worked remotely at least part of the time. But that's not the reality for most Americans. And that is the economic structure that we're, of course, working remotely, mapped on directly to lesser risk of getting COVID. And of course, that risk of remote work or not remote work is unevenly distributed across racial and ethnic groups. So this looks at black workers being more likely to be frontline workers and more likely to be things like grocery store workers, public transit workers, trucking, building cleaning services, healthcare workers. And these are the occupations that were exposed to higher risk of COVID right from the beginning of the pandemic. So inequities in exposure to COVID and the underlying health inequities resulted in inequities in then burden of COVID in terms of when you get COVID, having severe COVID. Why is that? Well, because we've known right from the beginning of the pandemic that one of the biggest risk factors for severity of COVID is underlying illness. Well, underlying illness is socially patterned and economically patterned. This looks at income decile. The yellow bar is having prior illness makes you vulnerable to COVID, and the more income you have, the less likely you are to have prior illness makes you vulnerable to COVID. And again, that is unevenly distributed by race. When you look at black Americans, white Americans, black is blue, white is red. Higher high blood pressure, higher diabetes, young ages, middle ages, older ages among black Americans compared to white Americans. So these underlying inequities of underlying morbidity, inequities of underlying social economic opportunity became the inequities that we saw in COVID. Third is communication challenges. Now, communication challenges is gets everybody riled up, I realize. Although it's very easy to say things like, well, it's all sort of the fault of the executive branch at the time. I actually think it's far too easy an answer to say it's the fault of the executive branch. There are abundant number of errors that were made by the executive branch at the time. But fundamentally, what this reflected was an event that coincided with the run-up to a presidential election that was built on a country which was getting increasingly polarized. This looks at Democrats, Republicans, ideological divides, 1994 overlap in blue and red, 2014 much less overlap in the blue and red. And all of that went to then politicize what happened in COVID and to politicize the communication around it. The CDC has been much maligned in this context, and I think that's unfair. I think CDC has actually done really an enormously positive job given the conditions that they were dealt. And as I'm going to get to in a second, the CDC fundamentally was ill-equipped to deal with this kind of extreme polarization in that we had set up a public health agency to deal with a world where we could actually find consensus, which clearly was far from it. And then we saw that, of course, play out in things that are as really as small as the issue of mask wearing, where mask wearing, because it became, we started off with the science saying, not so clear, masks make a difference, to then shifting, right? Mask wearing became something that had totemic significance for both sides of the argument, and we failed at communicating how the science evolved to illustrate when mask wearing was adaptive and when it was not. So those are the three sort of reasons that led to, I think, what really went wrong. And then we get to the roots of these problems. So what are the roots of these problems? And the roots of these problems, of course, point us then to what we should be doing. And I argue for three roots of the problems. We've underinvested in systems, in health, and the politics and the science have become conflated. So let me talk about each of them. Let's start with underinvestment in systems. Well, we have, insofar as you are trying to design a virus to create a pandemic that will wreak havoc, we could not have been more sitting ducks than we were. Why? Because we were actually underinvesting consistently in any form of public health infrastructure that could help us. Right? This is our underinvestment in local and state public health workforces. This looks at state funding on, this is change in staff per resident and change in expenditures per resident. The more the brown, you see a decrease. The vast majority of states have decreased number of public health staff and expenditures per resident over the past 20 years. Most states spend less than $100 per person on public health. The darker the brown is closer to $100. And even though there have been efforts like the Federal Prevention Public Health Fund as enacted, what ends up happening is we end up underspending on these and we tend to chip back in public health. Most local health departments don't have epidemiologists. Only about 28% of health departments have epidemiologists. And most state and local governments spend less than 3% on public health. So if we were trying to create a system where we were ill-prepared to deal with a pandemic, well, we were doing a good job because this is exactly what we did. You know, if I come back to CDC for a second, and I come back to CDC, which got criticized a lot for many things, including, for example, CDC's failure at developing a test that we needed at the right time, right? And I think we can all agree it would have been good for CDC to develop a test. Well, who at CDC was actually charged with developing a test? And, you know, this is from a BuzzFeed sort of, a FOIA inquiry. And what they point out here is that the developing the test fell on a CDC lab with only 3 employees. So we as a country were fundamentally waiting on this critical test in the lab and 3 employees. Now, I suspect many of you have run labs with 3 employees, and you know that doing anything quickly, urgently with 3 people is just, you know, really hoping that nobody gets sick and nobody's child gets sick and all that. That's exactly sort of how we had built this. You know, ironically, perhaps given how these forces collided, is that most states and local governments spend more on policing than they do on health throughout much of the country. And that, of course, perhaps tells the story of the forces that collided to bring us to the place that it did in the summer of 2020. So that's underinvestment in systems. Number 2 is underinvestment in health. Now, we should be very clear that we actually invest a lot of money in health, but all of the money we invest in health goes to healthcare. So this is our spending in healthcare. This is us compared to other high-income countries where we spend more. Our rate of change is higher, and our rate of change is also higher than other countries. But that's the blue is roughly what I showed you before, healthcare programs. All our other spending, this is projected out to 2034, leaving aside Social Security, has been going down. Now, this is true sort of everywhere. You know, I'll show you Massachusetts data. This is Massachusetts, which is, of course, together with California, perhaps, you know, seen as one of the most progressive states. This looks at our spending over a 15-year period. Healthcare spending going up 100%, spending on transportation, housing, primary, secondary education, mental health, higher education, early childhood care, environmental recreation, going down or staying the same. I actually don't know what the equivalent in California is, but I bet it would be pretty similar. So fundamentally, we as a country have underinvested for a long time in what we know generates health. And we know this. I mean, this is sort of within a distinguished academic medical center like this one, we recognize this. We know that it's about poverty, it's about stable housing, it's about people having opportunity for recreation, it's about loneliness and mental health. We actually know that, but we often find ourselves a little bit of a loss for what to do to move forward a world that actually invests in these forces in much the same way as it invests in healthcare. And we have a harder time recognizing how deep our underinvestment in the forces that generate health are. So to take one concrete force, which is the accumulation of assets and wealth, which is perhaps the single most directly associated exogenous variable with health. Well, there is an enormous black-white difference in wealth accumulation in this country, which I showed you earlier. Well, where does that come from? Well, that comes from the historical legacy of slavery and Jim Crow laws. And just to give you one concrete empiric example of that, this looks at redlining. Redlining, which we've all heard about, we've all discussed, comes from the 1920s, 1930s, federal program to encourage Americans to own homes. Well-intentioned program, the formation of the Homeowners Loan Corporation, and they would take maps of cities, this is Detroit, and they would mark them up to encourage or discourage lenders from lending money. Red discouraging, green encouraging, this is Detroit. Red area discouraging people from lending, which is of course areas where Black Americans lived. That line right there, sharp line, is 8 Mile Road in Detroit. That pattern of discouraging lending to buy homes remains a pattern of marginalization to this day. This is Black Americans, white Americans, segregation across Detroit. And that can be directly linked to health today. This is the same map of redlining just rendered in GIS. This is a map of foreclosure of homes in the 2008 recession. And the darker the color here is the worse health. It's a map of poor health. So you can trace over a century the legacy of marginalization that becomes a disinvestment in health in the present day. So that then maps onto a pandemic hits, and we as a country not only fail technically in terms of not vaccinating people, but also have underlying illness, this is obesity, which makes us, as I said earlier, sitting ducks for the consequences of COVID and sitting ducks in a disproportionate way. So that's the second underlying reason. Third underlying reason, politics and science. Now, there's much in politics that we can blame big P politics, electoral politics, but I actually would like to talk a little bit about the politics as it intertwines with the science, as it intertwines with health. And I'd like to start off with the argument that you can't separate politics from health, and we never should. And in fact, in the public conversation, it's never separable. This is from an analysis from Professor Jacob Bohr. On the x-axis, you have change in life expectancy over a 40-year period. When you get to the right, you have life expectancy improving. On the left, life expectancy getting worse. Each of the bubbles is a county. On the y-axis is share of the vote in those counties that candidate Donald Trump got. So the counties that were doing better, very low vote for Donald Trump. Counties that were doing worse, higher vote for Donald Trump. Now, you can say all you will about this, but to my mind, if you're living in a county where life expectancy is getting worse, and you have two candidates, one candidate who says, things are going well, vote for me, I'll carry out my predecessor's policies, and the other candidate who says, we're going to rip up the playbook and do things differently, it strikes me as not at all unreasonable for these counties to actually vote for candidate Trump. And I think this has been a blind spot of all of us in health, to recognize that there is a very real linkage between health and political decisions, and that we in health are inextricably part of this political process. Now, we're inextricably part of the political process, and we also have our own politics. And I think it's important that we remember that we have our own politics and our own biases that we bring to the table. Let's think about COVID for a second. This is above the line are doing better, below the line doing worse on a number of dimensions: mental health, personal finances, job security, take-home pay, physical health, personal life, work-life balance. You see, everybody's doing worse. Everybody's doing worse on everybody's below the line. But above the line, you have this group right here. And this group right here is all of us, people with a postgraduate degree. So we did okay in COVID. Now, why does that matter? It matters because it influences our biases and how we intersected with the COVID moment, how we did our science, and how we saw the world. And I actually think that part of understanding the politics and the science is actually being upfront about these things and starting to unpack them as we move past the COVID moment. This had impact for how we did our science about things like school closure, recognizing, for example, that schools in more affluent areas have done much better than schools in less affluent areas, and how should that have informed how we thought about the consequences of our science as it influences school closures. And in no small part, we in the science muddled through this highly political moment because we adopted orthodoxies very quickly. And we actually did not allow space for what really, I think, makes us strongest in science, which is a plurality of perspectives and disagreement, even disagreements that we find unsavory. My favorite example of disagreements we find unsavory, for example, is disagreements about the Great Barrington Declaration, which actually had a lot of things in it that are unsavory, a lot of things I disagree with. But I contend that our effort, and fairly systemic effort in the part of population health, to not listen to even some of the ideas in the Great Barrington Declaration is a sin far greater than the elements of the Great Barrington Declaration that many of us find unpalatable. I mean, the Union of Concerned Scientists run at the same time say, herding people to slaughter, dangerous fringe theory behind the Great Barrington Declaration. And this suggests that scientists, fellow scientists, are not operating in good faith. And I don't think that is a good precedent that we want to set. And I think we allowed ourselves to get swept up in the politics of the moment. And conversely, our biases and our political positions led us to support things like this, like zero COVID. Zero COVID, which was strongly supported by the science, features an editorial in The Lancet, no less, the case for no COVID. There was never really any hope that zero COVID could be realistic. There's never really any hope for zero COVID because we actually have no experience at eliminating anything remotely like this. We've only eliminated one disease, smallpox, everybody knows, and smallpox doesn't transmit in animals, which means actually we had no real hope of eliminating COVID. But our scientific advocacy that got politicized around zero COVID gave license to what's happening right now in China, which is millions and millions of people under lockdown, under fairly draconian conditions that I think we can probably argue runs very much against the fundamental principles of creating a world that is healthier and better for people that we're aspiring to. So those are my three sort of underlying conditions. So coming back to then a summary of this, to move us to what should this mean for us in doing health. Here's my argument, is that overall burden was bad, inequities in burden, social fracturing. That's driven by technical shortfalls, antecedent inequities, communication challenges. And that's driven by underinvestment in systems, in health, and the politics of the science. So I say that then to say, okay, what does that mean? And where should this take us? So look, where should this take us forward? And I argue, staying with my rubric of threes, that means three things. That we should focus on health, we need a better value-informed science, and we need to shift the health conversation. So let me talk about each of them. Let's start with a focus on health. So what does a focus on health mean? Two things. It means we need to transform how we think about health, and we need to learn from COVID to inform other conditions, not just to inform the next pandemic, but to inform our thinking about other conditions. So let's start about transforming how we think about health. The good news or the bad news here is that transforming how we think about health has been right in front of us, has been a challenge for us to rise to long before COVID. The fact that we as a country so underperformed in time of COVID, it actually would have been shocking had we not underperformed in time of COVID. Why? Because we've been underperforming on health for a long time. This is our health achievement. This is until about sort of late 80s. We were doing better on health than all other high-income countries. Since late 80s, early 90s, we've been doing worse on health than other high-income countries. What about that picture? Just this one slide, ignore all my other slides. What about that slide would make us think that we're going to do okay in COVID, right? We knew we're not going to do well because we know that insofar as this is the figure from the Institute for Clinical Systems Improvement, healthcare causes part of health, but so does health behaviors, where we live, education, job status, etc. And we have massively paid less attention to that than we've had to. It would have had to be a very strange pandemic that didn't depend on all of this, right? So we actually should have expected that this would happen. And there was an argument to be made for all this long before COVID. In fact, some of us made that argument long before COVID. This is actually a piece I wrote in March of 2019, which just goes to show you the depth of my influence that was roundly ignored. But essentially, this piece in 2019, which says we need a Health New Deal, says essentially everything that I've said so far. And there are many others who've actually been saying this. So it's not new. The question is, can then we use COVID to galvanize a focus on these ideas that have been with us for a while? And can we also make sure that we learn from COVID, that our learnings from COVID do not just go into better vaccination, better stockpiling, and better medical care? That actually what we learn from COVID moves out of the sort of COVID exceptionalism lens and to move to thinking about health more broadly. So this is a piece which I did recently in General Health Forum about moving beyond COVID exceptionalism. And the idea is that during COVID, it hasn't just been about infectious diseases, right? This is Stroke, Alzheimer's, diabetes, hypertension. On the x-axis is months of the year. The blue bars are deaths in the time of COVID, and the dark blue line is the average in the preceding 5 years. So we've had more deaths from all these other diseases. We've had excess mortality from a whole range of diseases in the time of COVID. We've also had a disproportionate burden and increase in mental health. This looks at depression. Pink is before COVID, the red after COVID. Mild, moderate, moderately severe, severe depression all went up. They've all gone up about 2 to 3-fold. And we've had an extraordinary increase in other diseases. These are things like drug overdose. Drug overdose went up about 30% in the year of COVID. 100,000 Americans died from drug overdose in the first 12 months of COVID. A lot of it linked directly to mood anxiety disorders, depression, ready availability of synthetic opioids. So as we are thinking, as we're emerging from the pandemic, and as we're starting to say, how should we change the health conversation? We need to make sure that when we think about sort of what's likely to shape post-COVID healthcare, this is from a McKinsey report, right? What's likely to shape post-COVID healthcare, which is all fine, except none of this even remotely begins to address anything I've talked about. And this is from another report which looks at advanced primary care. Again, it's all fine, but it doesn't address anything I've talked about. So I sort of feel like one has a choice. You either say that I'm wrong, which is fine, then we can have that conversation. But if I'm not wrong, then why do we keep missing these elements? Like, why do we keep missing these elements from these actually thoughtful, well-meaning efforts to envision health and healthcare beyond COVID? So it seems to me like it is the time to say, let us incorporate these elements into how we think about health and do the hard intellectual spade work to figure out what does it mean to incorporate these elements. You know, I'm not sure I know what it all means, but I'm pretty clear that what happened in COVID was entirely predictable because all the data led up to it. What happened followed a prescribed script, and it will happen again unless we actually change our thinking. So that's number one, thinking about health differently. Number two, a better value-informed science. I actually, for better or for worse, I actually believe in what we do. I actually believe in the science. I actually believe that it is a noble profession to generate the ideas, to generate the data that informs how the world thinks. But because I think it's a noble profession, I think we need to hold ourselves to a really high standard. We actually in the science have an extraordinary privilege to be in a position where, you know, we have relatively little societal oversight. Like, you know, we control ourselves. And that means that actually we need to be better at rising to the level society needs us to. And we, I would give us a C at best as to how we did during COVID. So, my thinking on this, 3 things. Epistemic humility, radical compassion, and thinking about reform and through reason. So let me talk about each of these. I'll start with humility. This is a quote from a paper which I quite like about modeling, which says, with a lot at stake, it's wise to be humble when faced with fundamental limitations. Now, everybody in this room knows that the science we do is faced with fundamental limitations. We all know that. But my question to you all is this. How humble has science been in its engagement with this moment? And I would argue not very humble at all. Now, we can talk about why that is. We can talk about the distortions of the public square as lived out in social media. That's fine. We can talk about the reasons why. But I actually would argue that science intersected with the moment with a dispositive approach to things that we had not yet sorted out. And clearly we ran against a problem in thinking quickly and working through our mechanisms quickly and conveying uncertainty where we had uncertainty. Every good scientist knows that there's uncertainty in what we do. But we did not transmit that to the population, and I think that is to the detriment of the world. We embrace things like my least favorite mantra, the follow the science mantra, which suggests that science had easy answers and puts us in a position, the very awkward and misleading position, that actually were easy answers that from somebody's lab was going to emerge. Here's the right answer to do. When rather, what we should have been doing was illustrating how science is part of a complex set of political decisions, and it was on us to engage with those and engage with those honestly. It seems like one of the things that challenged us in science is that we were uncomfortable admitting that there was uncertainty. And the argument that is often posited on that is, well, if we say we're uncertain, people won't believe us then. But it's actually not true. There's actually science on that. And this is from one example. This is effects of communicating uncertainty. Communicating uncertainty only exerts a minor effect on trust. Knowing this should allow academics and science communicators to be more transparent about the limits of human knowledge. So actually, we in science, we're not listening to science. And compassion. Compassion would mean recognizing that the consequences of tragedies like this are unevenly felt. And as such, we have a responsibility to focus all our intellectual resources in helping those who need them most. I mean, things like the extraordinary GDP decline results in job loss, not felt by us, not felt by our friends, but felt by people in a totally different socioeconomic stratum. In fact, jobs have increased among the wealthiest 25%. The jobs that have been lost have all been in the bottom half of the population income. Jobs have been lost. Our jobs I showed you earlier were the high-risk jobs in retail, in house cleaning, in truck driving. Those were the jobs have been lost. In fact, when you should look at this data from Bureau of Labor Statistics again, in the highest income half, jobs have been gained. It's in the lowest income half that jobs have been lost. And these are the same jobs, taxi drivers, firefighters, cleaners, etc., that have been at highest risk. You know, interestingly, when you go back in time, go back to the arc of time and the arc of pandemics, I started off by talking about the Black Death in Europe. One of the consequences of the Black Death was it was the beginning of the end of the feudal system, because there were so few workers left that the feudal system started falling apart. And you know, I'm extending that metaphor to the moment, but of course we're seeing many of the same social phenomena in the moment, right? We're seeing now workers having much more bargaining power as we emerge from the COVID pandemic. So I am not completely pessimistic about the fact that actually positive things can emerge that can result in some needed economic restructuring so that we can actually protect parts of the population that have been so vulnerable as, when COVID happened. And then thinking about reform guided by principle, thinking about principles like health equity is from a paper that we did, talking about equity as the just and fair allocation of resources according to need in a way that preventable difference in health outcomes are minimized and access is fair. And that is quite far from actually where we are as a society, even though that was the pathognomic problem of what happened in time of COVID. And you know, I'll end with this one on this point. This is a piece I wrote about dignity and about us in science recognizing that our goals for health and health achievement should rest in the values that people hold dear. And that means having clarity about why we're doing what we're doing, having clarity that health is a means, not an end, and that our job is to create the conditions for a better, healthier world. And the third aspect is the health conversation, that fundamentally all of this calls for a change in the health conversation. This is a book I did just before COVID, and I showed you a picture of this book because the title of this book was the subtitle, which is what we need to talk about when we talk about health. That's actually what I submitted to the publisher, and the publisher said no one's going to read a book with a title that long, so they added the word well, because that was a short word. But really what the book was about was this. It's about we need to change what we need to talk about when we talk about health, and I haven't changed my mind on that. Now, I often, when I'm talking in rooms like this, I get people who think about these things carefully, and you know, I get a reaction of like, well, yes, this stuff is obvious. But it's actually not obvious to the population, like not at all. This is from a recent survey that our team did, asking people what primarily causes your health, you know, check things off. Most people identify healthcare. In fact, only 3% of people even mention politics as affecting their health. If I were to answer that, I would put politics first, right? But this is the general population. By the way, if it's in a constellation, this is true across 8 countries where we did this survey. It's actually true universally. So if these things are obvious to us, they're not obvious to the population, and it's on us to actually bring the population along. And you know, there's been a shift away from this over time. This is from a Surgeon General's report that came out in the last day of when Surgeon General Adams was there. It's actually the closest Surgeon General has ever come up to a social determinants of health report. And what this looks at is, if you look at the bottom panel, these are landmark achievements. The brown are landmark achievements in public health, things like sanitation, abolition of slavery, libraries, conservation of parks, etc. The purple are landmark achievements in medicine, biomedical training, antibiotics, DNA, etc. But the relevance here is then they did a bibliometric analysis looking at the public conversation. The brown is the conversation about public health. The purple is conversation about medicine. You see, starting about mid-60s, right, the conversation has totally shifted. I want to be very clear. None of this ever, nothing I ever write, anything I ever say, is ever against medicine, against biomedicine. I actually think that biomedical research is among the jewels in this country, and when I'm sick, I want the best possible doctor and nurse to look after me. All it simply says is that we need to shift the narrative to see medicine as part of the larger endeavor of promoting health. And when you look at the books on health, you know, just Google and Amazon books on health, you see that the narrative is a narrative one of clinical care, of restoring people to health rather than keeping people healthy, and I think we need to shift that. So I'll conclude on an optimistic tone. I was talking earlier to some colleagues. It was a great conversation. And I'm clinging to optimism. I'm clinging to optimism is because I actually think we have done great things in the past. And I think even COVID illustrated some of the things that we're capable of. So number one thing that COVID illustrated was actually we have outstanding health systems in this country. We have outstanding hospitals in this country. And I know it sounds counterintuitive given the burden of COVID, but actually the data are pretty clear that when people were in hospitals, they did quite well. I mean, this is one example. This looks at data from New York. March of 2020, new disease, people come into hospital, death rate of 25%. 3 months later, death rate is down to 5%. 4 months later, down to under 5%. With no therapeutics, no vaccine, right? Our system figured out how to deal with sick people, developed all sorts of approaches, and we started keeping people alive. And in fact, when you look at within hospital data, there is very little evidence, for example, of inequities in outcome within hospitals. There are inequities across hospital systems, but within hospitals, we actually did really well. And to my mind, that is a perfect testament to the fact that we've invested a lot in hospitals and healthcare. And actually, we are reaping the benefit of that. Of course, the ultimate reaping the benefit is mRNA vaccines. This is a paper published in 10 years ago, 2012. I love this paper because I wish in my life I could once write a sentence like this. 10 years ago, mRNA presents a promising vector that may well become the basis of a game-changing vaccine technology platform. I'm like, wow, that is so cool. They really saw it, right? 10 years ago. That's exactly what happened. But of course, it shows that we've invested in mRNA vaccines for the past 20 years, and the benefits that we reap are actually directly linked to what we sowed. And then fundamentally, we as a world have improved our health immeasurably. For 50,000 years of human species, our life expectancy hovered between 30 and 40. 150 years ago, we actually transformed the world, and our life expectancy jumped to about 80. I mean, that's remarkable, right? So I can't help but feel, and I said this earlier in our small group discussion, there are a lot of challenges, but I'd rather live today than at any time in history. And frankly, if given a choice, I'd rather live tomorrow, because I actually do think that we are changing the conversation. And I do think that if we actually think strategically about how to focus on health, to do a better science and shift the health conversation, we can extract from this tragic moment something positive. My book, which came out in November, was called Contagion Next Time, which actually addresses a lot of these issues just with better anecdotes. I'll stop there so we can have comments and questions. Thank you for having me.
Sandro, thank you very much. I hope we can get access to those slides because there's some really great media there.
You're welcome to all of them.
Thank you. And we talked about this a little bit in our pre-talk meeting. Mm-hmm. The extent to which public health conversations, the conversation about public health that you've been talking about, the way we can change the way we're talking about health, has become tied up with political identity, is problematic, obviously. Mm-hmm. Can you talk a little bit more about how you see communication and changing the conversation as a means to break through the kind of ways in which personal and political identity has become enmeshed with public opinion about what generates health and what we can do to generate better health?
Yeah, that's a very hard question. It's a very hard question because the entire academic enterprise has aligned itself with one side of the divisions that characterize this country. And I don't mean that critically. I actually think it's perfectly reasonable, particularly when one side, to use the term, and I'm using the term side judiciously, has embodied principles that actually arise from the science, particularly from the science of public health. So I think it's entirely understandable. But be that as it may, I think it's actually critical for us to understand how the other half, and it's really half, of the country feels about things. And it's not good enough to say that we're right, they're wrong. And I'm using the term we and they, again, intentionally. I think fundamentally, we need to make sure that we actually see our role as bridging these gaps. Because fundamentally, we are about the health of the public, not just the health of half the public. Or the health of half the public will go along and the other half will then insist they come along. And because we all saw how well that works, it really doesn't work well at all. So I think it's sort of on us. Now, I think there's a bit of a temptation to say, well, why is it that we have to make the effort? Well, because that's how it works. I think it's, when you have access to expertise and knowledge, it is actually on you to make the effort to bring people along. It's not on people to come along spontaneously. So I do think it is on us to bridge those divides, hard as that may be.
All right, I have a question that's come in on Zoom, although I also had a request that people introduce themselves. So, Dean, quickly introduce yourself.
Dean Schillinger from San Francisco General Hospital.
Thank you. All right, so a question that has come in online is from Bern Shen, who is a member of our National Advisory Board for IHPS. Thanks, Bern, for being there. He asks, do you have suggestions for what biggest bang for the buck actions ordinary citizens can take to improve public health?
Yeah, I think the biggest bang for the buck for ordinary citizens, to use that term, is engaging in the act of conversation shifting. And I've sort of challenged, quote, the term ordinary citizens before to say, have a conversation about health at wherever you are, at dinner, at a bar. Start a conversation about health, well, however you want. Say, I happen to see this talk about health. And see how long it takes for people around you to use the word healthcare interchangeably with health. And it's always less than 5 minutes, I promise. And use that as a teachable moment to actually explain what it is about what health actually is. And because I think until we get to a place where around the proverbial or actual kitchen table, grandma says, what matters for my health is that I have a roof over my head, and I want to make sure that's a core part of my health. Until we get to a place where in presidential primary, one candidate says, well, let me explain how my housing plan is going to improve people's health. Till we get to that place, we're going to continue having this divorce from our health and what actually drives it. And we're going to continue having that figure I showed, right, with the sort of us going into the red compared to other high-income countries. And until we fix that, it doesn't matter how good we are at dealing with vaccines. It doesn't matter how good we are at making sure we have resilient health systems. The next crisis will affect us as negatively as this one has.
Laura Schmidt from IHPS. This was a really great talk, and thank you for just synthesizing. We're all still shell-shocked from the experience, and it's great to start the conversation about what can we learn. The one slide I didn't see in there that I kind of was expecting to see is the secular trend in inequality, economic inequality. We are at the 30-year apex of economic inequality, which really makes me wonder, is the conversation even about health? Or should the conversation really be about structural, the structure of our economy and the new Gilded Age?
Yeah, I have the slide, but it's I edited it. That's right. When one defines health equity as the equitable distribution of resources such that preventable differences in health can be prevented. That was the definition I showed you. I went through it quickly, right? So we're all here we're all like raw health equity. There's not a single person in this room, physical or Zoom, who is not raw health equity. But the definition is the equitable distribution of resources so that, right, equitable health can happen. And we are raw the second part, and we are pretty glib with ignoring the first part. The first part is about the equitable distribution of resources and assets. Now, that's a big sentence. Like, that really is a very big deal. It's a very big deal intranationally. It's an even bigger deal internationally. I mean, we can all say, again, in terms of health equity, well, it's a tragedy that life expectancy in Malawi is 47, while in Japan is 80. That's unacceptable, right? Okay. Well, what's driving that principally is the inequitable distribution of resources between Malawi and Japan. And what are we willing to do about that? And so I actually don't think that we are willing to have the difficult conversations that it would take to fix that. Now, I was making a comment earlier to somebody that when I say things like that, I'm often mistaken for a socialist. I grew up in a socialist country, which means I have no love for anything but a market-based economy. I would be very clear about that. But actually, I don't think the two positions are incompatible. I think one simply needs to recognize that these positive externalities emerge from a carefully thought out economic structure that recognizes that you need to narrow asset gaps in order to narrow health gaps. You know, I wrote a piece with my good colleague, Dr. Mary Bassett, arguing that a very compelling argument for black reparations is simply narrowing the black-white health gap. There's many arguments for black reparations, but I was simply trying to make the point that I don't see a way to, in our lifetimes, to substantially narrow black-white health gaps without some form of restitution of assets to a group that has systematically been excluded from the accumulation of assets. But that sentence that I just said is very far from where we're at in the national conversation.
All right, we've got Rita and then George. But first, I've got somebody online who was ahead of you. Flavia Chen asks Dr. Galea, what opportunities do you see in long-term sustained funding for public health beyond the technological interventions or investments in data systems, surveillance systems, et cetera? It seems that making an economic argument for prevention will continue to be a challenge.
Yeah, it's an excellent point, and I suppose the only way I know how to answer that, and I really don't know how to answer it, is that perhaps COVID is a moment. It truly is a pivot moment, truly is a teachable moment. And if that's the case, the world will be better for it. If that's not the case, it'll be a tragedy for naught. So I think there are so many arguments that can be made through the lens of this COVID moment. And my challenge to us all is, if we don't make those arguments, then who will, right? Or like, it is on us to make those arguments. So I agree. I think the economic argument for prevention is difficult to make. It was difficult in 2019. Maybe it's a little bit easier in 2022.
Hi, Rita Redberg. I'm a cardiologist at UCSF. And I've now had the pleasure to hear 3 lectures from you in 3 years, and they were all different. I don't think any slides overlapped, and they were all fantastic.
Thank you. It's very kind of you.
I was glad to hear that you are still optimistic, but I also heard you say that healthcare, and I agree with you, is not a huge contributor to our health. And then you said you were optimistic because we have good healthcare in this country, and I agree we do, but I think we've overinvested, like in hospitals and that kind of healthcare, and under, as you said, in public health. And Pfizer and Moderna or whatever did really billions dollars well in this country, from COVID. I don't think the rest of public health didn't do so well, and of course a lot of people are concerned about the CDC and the communications issues. I mean, is there something that gives you optimism? Or what can we do, as you say, to learn and teach and improve our public health infrastructure, which I think has a much better chance of correcting the disparities and inequalities as much as we can do through health. Certainly economic equality is really foundational.
Yeah, I mentioned earlier in a small group conversation that I see optimism, to quote somebody, as an act of political resistance, and I prefer it to the alternative. But I think there are things that give me optimism. I do mean what I said, that when I do a critical analysis, critical reflection of which point in history would I rather live in, I'd rather live today than 10 years ago. Deeply troubling issues in this country, things like systemic racism, for example. Let's just take that. It's a really troubling, difficult, centuries-long issues. But we are having the conversation today. Now, you could argue it's only in some circles. Like there's many flaws in how we're having the conversation, but the conversation is happening in some places, and that gives me optimism. I have the privilege of being a dean of a school, and one of the things that comes with that is I see that, every year comes a new batch of students, and they're great. They're just good, and they're better. I can benchmark where I was when I was at their stage, and they're better than I was when I was at their stage, and that's good, right? That's positive. So I think that gives me optimism. And Professor Lowenstein mentioned at the beginning, which I really appreciate and resonate with, sort of the importance of what we do. And I said this in my talk. I believe in what we do, and I do see the conversation shifting. You know, some of these topics I talk about, like things, let's take something like housing, right? It's very difficult for health to know what to do with housing. We should acknowledge it's very difficult. But I've been in several conversations with private sector colleagues in the past 5 years, where they say with earnestness, how should we be tackling the issue of housing? I was talking to the chief medical officer for Walmart a few months ago. And, you know, Walmart, by the way, is the largest employer in this country, secondary to the Defense Department. And, you know, they're trying to wrap their brain around, you know, what can they do about these things. Now, will they do something significant? I don't know. But I know that 10 years ago, Walmart wasn't thinking this way. So I see these tendrils that give me optimism. And I'm sticking with optimism.
Right, George.
Thanks, Sandra. It's great to see you again.
Good to see you as well, George.
Since this is a health policy lecture, I thought I'd ask a health policy question. Public health is wildly decentralized in the United States. And having worked at the county and state level and the federal level and the WHO level, you can see how different it is at those different levels. 95% of public health law in the United States is state law, just as an example of that. How do you see this evolving? Because as we deal with bigger and bigger public health issues like climate change, you know, the city and county of San Francisco can only pass so many ordinances that are probably going to be largely meaningless. Now, California can do more and has, but, you know, at some point somebody has to sort of take the bull by the horns at the supranational or at the national levels and really push a public health agenda and get it organized so everybody's going in the same direction.
Yeah,
what you think about that?
No, I mean, not surprisingly, I agree completely. You know, Massachusetts, where I live, we have, 360 health departments, and which has resulted in an utterly chaotic approach to a lot of the things that were need to be done in time of COVID, which resulted in people not trusting what health departments do. You know, one of the anecdotes I actually have written into the book that I'm working on now is, you know, it's a bakery I like in town I live in, and recently the town I live in, the health department dropped mask mandates. Okay, and on the bakery has a sign on the door that says the following: "We know the town has dropped mask mandates, but we still mandate masks in our store." Now, you're all thinking, okay, this is no big deal. But let me ask you this question. Can you think of any instance before 2019 when a bakery that presumably doesn't have its own medical advisors would have put a sign up on its door that says, "The medical experts said X, and we think you should do Y," right? Like, it was actually unthinkable. So I actually think we've lost a lot of public trust. And I think a lot of that has come from this tremendous fragmentation of public health. So I think that we are going to have to make some difficult decisions. I think these 360 or however many there are health departments need a reconsideration. We need consolidation. We need to make sure that that we have much more standardization, interoperability of data, and all of that. And that can only happen nationally. I think it can only happen through a national set of standards and through some action nationally. And there's been a couple, 2 National Academies reports, I think both of which offer reasonable roadmaps to doing that. Thank you.
Thank you
It's
so
a privilege
much.
to be here. Thank you, everybody.